Thank you very much for kind invitation. It is my great honor to participate in this session. So let's start my lecture, please. I would like to introduce the lecture, Use of MLD MAX and 3D OCT for bifurcation stenting. This is my disclosure. First of all, in OCT-guided PCI, there is a slogan, MLD MAX. For pre-PCI, OCT shows MLD. M means tissue morphology, L means lesion length, and D means lesion diameter. For tissue morphology, OCT characterizes tissue components. Fibrous plaque identified as homogeneous high intensity, and calcified plaque is clear border, heterogeneous, and low light attenuation. Lipid plaque is unclear border, low intensity, and high light attenuation. This is an example of calcified bifurcation. This is LAD and diagonal branch is here, and at the opposite side of diagonal branch, there's a calcium in there. So if there is a calcified plaque in opposite side of carina shift may happen after stenting. Load ablation recommended before stenting. So we have done a load ablation using a 2.0 millimeter bar. After load ablation, OCT shows ablation effect in there. So after stenting, stent is well expanded and no carina shift happened. If side branch angle is narrow and the carina is protruding to main vessel, there is a high possibility of side branch occlusion after stenting due to carina shift. Side branch protection procedure should be considered. OCT predicts side branch occlusion after stenting. For lesion length and lumen diameter, OCT autolumen profile display shows coronary lumen profile in all scan area. It will guide stent landing zone and help to decide stent length and diameter. It is a coronary map. This is an example of LAD diffuse disease, and MLD site is here. And if you decided to implant stent from here to here, the lesion length is 32 millimeter. And distal landing zone lumen diameter is 2.76 and proximal is 3.07. We usually 0.25 millimeter size up of distal lumen diameter, so we decided to implant the stent 3.0, 32 millimeter in this lesion. For example, in left main trunk bifurcation, stent diameter should be adjusted to LAD diameter, and pot diameter be adjusted to LMT diameter. Also, stent length and pot length must be precise with OCT information. For post-PCI, OCT shows MAX. M means stent edge medial dissection, A means stent apposition, and X means stent expansion. This is an example of Xylem Sierra 2.75 38 millimeter stent implanted. AptiView software automatically identifies the bifurcation region of side branch more than 1.5 millimeter. So there are two bifurcations in here. And you can understand stent apposition condition in here and the stent expansion condition in here. And you have to treat only the red area, so there is no remarkable malapposition. However, there is an underexpanded area in here, expansion index less than 80% like here. So you have to treat only this lesion with high pressure inflation. Also, 3D OCT gives image information such as stent cell figure, location of stent link in relation to side branch orifice, and guide wire recrossing position like this. For example, for left main trunk bifurcation, if we implant stent just as for LAD, remarkable malapposition happen at LMT. It is difficult to recross the guide wire distally because of straight form of the stent. If the guide wire recross proximally, After KVT, jail strut remains as distal carina. If we do proximal optimization treatment POT with bigger balloon, stent mother position disappear at LMT and easy to recross the guide wire across the carina due to the gap of the stent. If the guide wire recross distally, after KVT, jail strut move to side branch sites and get optimal result. Distal guide wire recross is required for optimal KVT. This slide shows the importance of POT for distal guide wire recross. Before POT, distal cell in here is narrow and difficult to recross the guide wire at this site. Actually, guide wire recross in the proximal cell. After POT, this stent is pushed by balloon and this space became wide and the guide wire easy to recross the distal cell. Also, we understand stent link disturbs side branch opening. If the stent link did not locate at side branch orifice, we call it link-free type. Optimal guide wire recrossing point is distal cell close to carina. After KVT, these jail strut move to the side branch sites and get optimal result. If the stent link locates close to carina, we call it link connecting to carina type. It is difficult to remove the jail strut by KVT. This is example, side branch orifice is here and stent link is here. And guide wire is crossing this cell. After KVT, this stent is crushed like this, and also by putting effect by kissing ballooning, stent struts shifted to proximal and no stent zone happened like this. Actually, this case, KVT causes harmful effects. This is another example of link connecting to carina type. This is the link is here and guide wire recross in the distal cell. After KVT, this stent crushed and also no stenting zone happened. And if the guide wire recross the proximal cell in the link connecting carina type, metallic carina remains at this site. All of this is a suboptimal condition after KVT. This slide shows the frequency of link-free type in each stent. Resolute or Archmaster is a 1.5 or 2 link, has a high possibility of link-free, and Giant's 3 link has less possibility of link-free. However, Giants has a unique link, peak to valley type. This is like a line and can changeable the length or shape. Other stent like a peak to peak type is point. It cannot be changed. This is an example of Giant stent implanted. Stent link is here, and after KVT, stent link elongated and adjusted like this, and disappear the jailed multiple strut. Below is a peak to peak type link stenting. And after KVT, still remain the jailed multiple strut in this side. So Giants has a little high possibility of link connecting to carina type, but high possibility of removing the jail strut. We are now conducting a Japanese 3D OCT bifurcation registry. The objective is to assess initial success and long-term prognosis in 3D OCT guided bifurcation stenting. Case number is 600 cases from 40 hospitals, and study period is for up almost 3 years. Study flow is 3D OCT guided bifurcation stenting, 600 cases, Giants 400, and other stent is 200. And we compare 3 groups: side branch opening, optimal KVT dilation, and suboptimal KVT dilation. And other group is stent side branch non-opening. We compare these 3 groups for 1-year restenosis rate and 3-year MACE rate. From interim result of 412 cases, left main trunk bifurcation is 24%, and LAD diagonal is 62%. True bifurcation is 40%. Procedural characteristics show radial approach is almost 90%, and the contrast dye volume is averages 146 cc. This slide shows the frequency of J-ring configuration and rewiring position. Among 279 cases, link-free type is 198, and link connecting to carina type is 81. Among 198 cases of link-free, distal cell recross was obtained in 187. And after KVT, optimal result was obtained, almost 67%. Other conditions like link-free and proximal cell recross or link connecting to carina type resulted in the suboptimal condition after KVT, 33%. 12 months clinical outcomes show cardiac death 1, and TVR is 9%, and renal failure have 1 case. I think 3D OCT is useful to guide optimal stenting for bifurcation and may contribute long-term prognosis. I would like to show 1 case, 73-year-old female, angina pectoris. You can see a 111 true type bifurcation in the LAD and diagonal branch. First of all, guide wire across the LAD and diagonal branch, and we have done the kissing balloon inflation using a 3.0 and 2.25 millimeter balloon. After KVT, OCT shows dissection in the diagonal branch here. This is a dissection in here. So we decided to implant the stent in cured type. First, Science Alpine 2.25 12 millimeter implanted from LAD to the diagonal branch site, and try to recross the guide wire to the LAD again. OCT shows giant stent link is here, and there is no link at carina site. This type is a link-free type. So ideal recrossing guide wire position is here. Actually, this time guide wire recrossing the proximal cell. So we have done the port to widen this distal cell. And then recross the guide wire again, OCT showed now this time guide wire recrossing the distal cell. Previously crossing this site. And then KVT was done using a 3.0 and 2.25 millimeter balloon. And OCT show this is a LAD orifice, no gel strut remain at this site. Science Alpine stent 2.75, 38 implanted to LAD. And then port was done using a 3.5. And this time OCT shows also there is stent link is here and no link at carina. So this is also a link-free type. And the guide wire easy to recross this side due to the port effect. And after KVT, final angiogram show a beautiful result. Now OCT shows there is no gel strut at bifurcation lesion, and also due to the culotte stenting, double layer of stent was observed. So this case was very lucky. Both stenting resulted in the link-free type after stenting. 7 months angiogram show no restenosis, like this. And OCT shows the giant stent has a well neointimal coverage, homogeneous high intensity, like this. And this is a side branch orifice here, diagonal branch, no gel strut. And this is double layer of stent. Looks very good. And pull back from diagonal branch. You see no restenosis. at the orifice of diagonal branch. Thus, I have shown a link-free type stenting procedure with beautiful result. The problem is how to manage the link connecting to carina type. In this situation, we usually do the novel push-forward method. The concept is a giant stent implanted crossover to the side branch. And at the orifice of side branch, stent link is here, is a link connecting to carina type. So we intentionally cross the guide wire proximal cell, and while balloon inflated and push strongly to push the stent to the side branch side. And then KVT was done. This protruded stent folded to the side branch side. This is one example of a LAD diagonal bifurcation, and stenting is here, and guide wire recross proximal cell, and while balloon inflated, push strongly to the side branch side to fold this stent to the diagonal branch side. And after KVT, you can see the folded stent toward the diagonal branch. So I would like to show one case, LMT bifurcation disease. And auto-lumen profile display shows the distal landing zone is here, and the lumen diameter is 2.25, and proximal LMT lumen diameter is almost 3.4, and lesion length is 38. So we implant the stent, Ultimaster 2.5, 38, crossover to the LMT. And we have done the port 3.5 in the LMT region only. And after this, we got an OCT. OCT shows stent link at the center of carina here, and there are two distal cells. If you recross the guide wire in distal cell, KVT causes a no stent zone and also stent crash. So we intentionally cross the guide wire in the proximal cell using an anchor balloon technique to the LAD, while balloon inflated, push strongly to the circumflex side like this. And then KVT was done, 3.0 and 2.5. After this, angiogram shows a beautiful result. And OCT shows this is a distal LAD and LMT site. Malapportion disappeared at LMT. And also from the pullback from circumflex, no geostrat at orifice of circumflex. 3D OCT shows a little bit geostrat protruded through the circumflex orifice, but the area looks very good. This is a before push and after push. You see protruded stent shifted distally to this side and get the wide open of the circumflex orifice. We understand there's a three pattern of geostrat removal by push-forward method. One is shifted or folded toward the side branch side like this, 50%, and strut shifted distally main vessel like this, just shift, not folded, 41%, and folded toward the main vessel in 9%. I think that folded toward the main vessel resulted in the compromising the distal main vessel area, so it should be avoided, I think. I think balloon push technique under the 3D OCT guidance is feasible and useful for removing geostrat over side branch orifice if the stent link is located at carina. OCT will guide bifurcation PCI with MLD MAX and 3D. Thank you for your attention.